In this video, we demonstrate how to place a tunnel dialysis catheter in the internal jugular vein. Step 1. Patient setup. The patient is placed in the supine position with the head rotated to the contralateral side. The neck and chest are fully prepped on both sides. The Trendelenburg position is not routinely used in our practice, but may be preferred in hypervolemic patients. Step 2. Ultrasound evaluation. The IJ is scanned along the neck while observing respiratory variations in its size. Spot compressions are performed to verify patency and absence of blood clot. Probe as far centrally as possible. Step 3. Ultrasound-guided access. We begin by injecting a local anesthetic agent at a puncture site. Next, using the mini-stick needle, puncture the vein under ultrasound guidance. We prefer to do our puncture with a lateral approach to the IJ. This enables an implant view of the needle. Note that the carotid artery is immediately adjacent, but with clear visualization of the needle. With this ultrasound view, it can be done safely. Here we can observe the backflow of blood through the needle, but this is not always present. The focus should be on observing the tip of the needle inside the vessel. Now carefully insert the access wire through the needle and watch it with fluoroscopy to confirm placement in the right atrium. Once correct placement has been verified, retrieve the needle and insert the mini sheath dilator over the wire.
We use only the dilator to keep the access puncture site small at this point in the procedure to minimize bleeding from the puncture site during the rest of the procedure.
It's important to hold a wire in place while pushing on the dilator to prevent guide wire migration. Step 4. Sizing of catheter length. First, slowly withdraw the wire until the tip is inside the mid-right atrium. Then, apply hemostat to the wire at the end of the mini sheath dilator and pull it out completely. The wires then place on the back table to take measurements. Mark the tip of the wire on the drape and mark the point where the hemostat was applied to the wire. This represents the entire length of the wire that was inside the sheath and the venous system. To obtain the exact intravascular length of the catheter, subtract 2.5 centimeters from the measured length. This accounts for the length of the externalized portion of the sheath, as shown here in the video. Next, proceed to reinsert the access wire on the fluoro guidance and withdraw the dilator. Now we return to the surgical drape to verify the measured length of the catheter. The additional marking you see on the drapes is to measure the first 15 centimeters, because that is how long our ruler is. In this case, the measured length is about 20 centimeters. Step 5. Proceed to inject local anesthetic agent along the intended tunnel site. Next, select your catheter and mark the intravascular portion as previously measured. The mark on the catheter should be placed at the puncture site, on the patient's chest, and the length to the exit site estimated. The exit site should be 1 to 2 centimeters beyond the cuff, as shown here in the video. Once this is done, step 6 is to tunnel the catheter. Begin by making stab incisions with an 11 blade at both the exit and puncture sites. Make the small incision in the neck along the lines of tension to allow for easy closure. Next, use hemostats to spread the incision. This ensures easy passage of the large devices. After this, the metallic tunneler is attached to the catheter in preparation for tunneling. The catheter is then carefully tunneled from the exit site towards the puncture site. A lateral approach is preferred for tunneling. This gives a natural curve to the catheter to prevent any form of kinking. If an anterior approach to the jugular puncture was made, a curved tunnel will need to be made from the exit site to the puncture site to prevent kinking. Step 7. Insertion of the peelable introducer sheath. To do this, we need to exchange wires. The mini-stick sheath is therefore reintroduced over the wire. The dilator and the access wire are removed, and 0.035 J-tip wire is inserted. We prefer to convey the IVC with this wire. This step is not mandatory, and the procedure can be performed just by leaving the 0.35 wire inside the right heart. After this, retrieve the mini-stick sheath and proceed to perform serial dilatation. Pressure is held at the puncture site with each exchange to prevent bleeding. Passage of the dilator and peel-away sheets are the most hazardous portions of this procedure. It is critical to ensure that the catheters are passing over the wire, and fluoroscopic guidance is used during this portion of the procedure. In this case, you see us moving the wire back and forth as the dilator is passed over it. This helps ensure that we do not kink the wire and push the catheters in an unwanted direction. Serious vascular injury can occur without great care taking out the stick. The peelable introducer sheath is inserted in the same manner as a dilator, with flossing of the wire while advancing the sheath. Once the sheet is inserted, remove the dilator and the wire. We note the absence of bleeding here due to the valve. Step 8. Catheter insertion. The distal third of the catheter is quickly inserted to avoid bleeding and gas embolism.
Break the sheath, pulling tabs down and away while maintaining a forward push on the catheter. Any resistance during the passage of this catheter should prompt use of fluoroscopy to make sure the catheter is not getting misdirected. With the other sheath complete, and verify correct placement with the completion fluoro, observe the tip of the catheter in the right atrium with a nice curvature, no twist or kinks.
Step 9. Test and flush catheter. Attach a 10 cc syringe to the port. Unlock and aspirate blood. Observe the easy return of blood. Repeat with the other port. If there is any resistance to aspirational flushing, further flow and possible use of contrast are needed to ensure good catheter tip placement and function. After this, flush the ports with normal saline.
Next, proceed to pack the ports with appropriate amount of heparin. For this catheter, it is 1.8 millimeters as indicated on the port.
Repeat with the other port. When this is done, lock and cap both ports. Step 10. Final step. Secure the catheter and close the incision site. The puncture site is closed up using buried 4-0 monocryl sutures. Next, a drain stitch is placed at the exit site to firmly fix the catheter to the skin. With this technique, we first tie an anchor knot, after which the two strands of the suture are wrapped around the catheter in a crisscross manner and then pass through the holes in the hub from back to front to tie another knot. This technique ensures that the catheter can be easily lifted up to clean the wound and place dressings, but at the same time, ensuring that it is well fixed to the skin and does not easily remove. Finally, sterile dressings are placed. We prefer to use the CAG dressing. Thank you for watching.